Hey guys, Dr. Dustin Judd here. Lumbar SI joints. I do a leg check. I do a leg check with them supine. You do not have to turn them over. She's pregnant. I'm sure she doesn't want to lay on her stomach today anyway. But I have not seen a difference. If you lay them on their stomach versus laying them prone, doesn't make a difference. I'm looking for the short side. The reason I'm looking for that, especially on a day one where it's their first adjustment, so I'm lightly pushing. She's got adjusted early today, so she's not really far off. If I had to just say she's shorter on one side, it'd be her left side. So that's what we go to. I'll always adjust the short side first. Why? Because that's just what I've always done. It always works for me. I find that I've gotten better results. I don't know if there's any scientific evidence or whatnot as to why that is better, but using the side that is gone anterior first or posterior first, posterior SI joint, it's just easier. So what I'm going to do is have her lay on her side, face me this way. Now she is pregnant. This table moves down. So when we do this, we want to, I would suggest that you find exactly your point of contact. Do not dig in with your thenar eminence. Like a lot of people are like, do this. I don't do that at all. I'm actually going to try to go around the SI joint with the palm of my hand because it's tender, right? A lot of times, especially when you're pregnant, these are very tender. The last thing I want to do is put all my force, all my line of drive into one. So I want to kind of diffuse that point of contact out just a bit. Now we're going to let this out for her just to give her a little more room for her baby girl. And I want to put right there. It's a lot closer than you think. So SI joints right there. I'm coming over. Where is that? It's right in the palm of my hand. So I'm taking that point of contact and I'm shifting it through my palm, and it just moved just then, right? Mm-hmm. So also, come up for just a second. Torque. This is important. This is the magic sauce when it comes in to looking at pelvis, SI joints, lumbar is your torque. So when you're line of drive, it should be like that through that adjustment. On the short side, which means it's gone posterior, that means we're rocking it. Our line of drive is going to be up, forward, and torque in towards the spine. So it's going to go up, forward, and in towards the spine. That's what it needs. We're going to keep this super simple. This is her short side. We know that this SI joint needs to go up and forward with a little bit of internal torque. And the opposite will be on the other side. So we're going to get this right. We're going to bring it forward, up, and in. I'm adjusting through my chest. I'm not making my elbow. If you don't want shoulder and elbow injuries and you want to do this 20, 30, 40 years and be a longevity chiropractor, if you will, then you have to do it this way. So when you adjust hundreds of people a day and you do it for days on end or weeks and years, and you're going to have to do it in a way that doesn't damage your body. So it's going to look just like this. I'm going to torque it in just like that. Very fast, very specific. Most of the weight, most of the force was done through my chest, right through my point of contact. And as I went down, I spun it. I put the torque to the inside, or internal torque towards the spine. And it is so smooth, so easy, so comfortable for the patient. And she's going to get amazing results. Because why? Because it's functioning really well. That thing is going to move amazing after we're done. So let's flip her on to the other side. So this would be her long side. So we know that we would be pulling this back. We're going to contact a little bit lower on the SI joint, not necessarily right on the ischium, maybe right between the SI joint and the ischium, but this time we're going to be driving down and out. That means our external, it's going to be external rotation. So same setup, I've got her here. Sometimes I'll let their leg drop. Let's do it for just this one right now. You don't have to, but I'll let their leg drop because we're going not up and in, but down and out, just like that. Like that, and I'm same thing, straight right through my chest, just boom, just like that. Now we'll help her up right there, just like that. Beautiful. We could have done a leg check. We should have done a leg check for you guys, but that's it. It takes a lot of practice to do cervical, thoracic, and lumbar just that smooth. How long does it take me to adjust an average patient? Probably a minute and a half, maybe. I do a leg check. And then I go straight into thoracics, do their cervicals, finish up with their lumbar and pelvis. I check everything every time. I don't have any weird leg checks like that. If it's not moving, we're moving it. I've never overwhelmed somebody's neurology, overwhelmed their brain by putting too much proprioception, flooding their cerebellum with proprioceptive information. I've never seen anybody crash or shut down. The worst thing you could do is leave something on the table because you just failed to address it or you failed to even know that it was there. And so we want our patients, we want great spinal function. We want results. That's how we do it. That's how we deliver it. We do it every single day, hundreds of times a day. Much love. Bye.